So our next speaker is Donald Redelmeier. Dr. Redelmeier received his medical degree from the University of Toronto in 1984 and completed his postgraduate training in internal medicine at Stanford in 1991. Has a master's degree in health services research as a Robert Wood Johnson Scholar at Stanford University. His research spans a variety of areas, emphasizing the psychology of medical decision-making and the epidemiology of motor vehicle trauma. He's published over 200 articles, several of which I'm sure most of you have read. He serves as the Canada Research Chair in Medical Decision Sciences and Professor of Medicine at the University of Toronto. Don, thank you.
Thank you all. It's a great honor to follow us, Salim and Dave. Thank you all for coming, for organizing your schedules, for traveling the distance, and for being willing to open your minds for a while. I'm going to speak for 20 minutes using 22 slides and making only one point, specifically to offer a new approach when randomization is not possible. The conference organizers were heavily insistent that I provide a disclosure of conflicts of interest, Salim, and so here they are. Nothing too ugly there except my own ego bias, which of course is every bit as forceful and sinister as a commercial interest. And it doesn't end there, because I can dream, and my potential conflicts of interest are virtually limitless. Here are 14 icons of some of the companies that I respect the most, and I am willing to pander in advance to any of them ahead of actual payment. Thankfully, however, all of these companies are relatively neutral when it comes to randomized trials in medicine. In terms of content, my first slides lists joyful strengths of randomized trials, and here are my favorite 10 of them. They are a great way of proving causality and were instrumental in the agricultural revolution of the 20th century. These studies can become immortalized in science and often have world-class craftsmanship. The writing is straightforward, and the publication process, not the regulatory process, but the publication process is sometimes quite easy. Post-publication marketing is quick, and subsequent refutation is rare. There are some opportunities for secondary analyses, as well as for fostering more grants. All of these points help explain why Sackett has been in love with randomized trials for decades, and nothing that I can say in this talk will ever change his mind. However, no form of science is ever perfect, and that's because each one of those 10 strengths also has a rebuttal. The inferences of causality in many randomized controlled trials have been challenged, such as whether the statin effect really has much to do with its cholesterol-lowering properties. The agricultural heritage is usually forgotten by most clinical trialists, including both of the talks that preceded mine. The clinical relevance of randomized trials is often quite transient, just like every study of cimetidine I read 20 years ago. The quality control is vexatious because a few outlier centers in the numerator can skew the entire results of 1,000s in the denominator. The writing easily devolves into formulaic text with absolutely no hint of creativity. The trials are slow to get published sometimes because they are slow to recruit the sample size, even if you can make it through all of the enormous bureaucracy in advance. The marketing can be awfully simplistic sometimes and leads to arguably an element of the dumbing down of science. The trials are costly, so costly that they are almost never replicated and therefore violate a core principle in science. The data sets are not usually made widely available from investigators outside of the inner group, and the grants are exorbitant sometimes and naturally propel an extremely conservative psychology for large foundations who need to have a return on their investment and do not want to embarrass themselves by misspending millions of dollars at any one time. Notice that this list of 10 criticisms contains none of the conventional complaints such as stringent selection, brevity bias, missing competitors, failures of blinding, and so forth. However, on my next slide, I want to show one more photograph of David Sackett from decades ago. And it is a classic baby picture and a reminder to let's not throw the baby out with the bathwater. No methodology is perfect. You need different tools for different jobs, and there is no denial of the past successes of some randomized controlled trials in my lifetime, i.e. folate for preventing spina bifida, tamoxifen for controlling breast cancer, statins for preventing myocardial infarctions. There are certainly lots of shining examples where randomized trials have made the world a better place. Now, so for the remainder of my talk, I want to discuss a substitute for randomized controlled trials when they're just not possible. If you need an image, then envision the Dow Jones Industrial Complex for 6 months in 1987. And if you want a name for this new design, I call it the exposure crossover design. And if you want to know its main strength, it's that it allows each patient to serve as their own control, which is the ultimate form of matching. Notice, however, that this graph of the Dow Jones Industrial Complex has several flaws in it. First is there's a chopped y-axis here, so that in 1987 the index did not fall by 80%, it only fell by about 25%. Second, that this entire analysis is really only of one aggregated entity and therefore is hopelessly confounded by all sorts of temporal trends such as the price of gasoline and the amount of air pollution. Third, this baseline here is not entirely flat. This drop is not completely abrupt, and this aftermath is not fully steady. Finally, this entire analysis is unrelated to medicine and does not study clinical outcomes. So in the exposure crossover design, we are now going to tackle all of those failures. Okay, so to do so, we now strip down the graph to its essential ingredients, namely a before and after comparison for testing all sorts of interventions. That is, by placing the patient as the unit of analysis and indexing time zero as that particular patient's day of intervention, and then following that patient both backwards and forwards in time, ideally for a hard outcome, not a surrogate outcome like a lipid level. Examples might include monoclonal antibody treatments for reducing relapses of Crohn's disease. It might include exercise training programs for preventing falls in the elderly, might include a bypass surgery for decreasing occurrences of unstable angina. The essential thing is that the outcome be repeated, recurrent, relapsing, or otherwise chronic, and that the intervention have a well-defined starting time. Now, on my next 5 slides, I'm going to use concrete examples to make this design more tangible. And I start with a large analysis of 500,000 women in Ontario who all gave birth to a newborn child on time 0, obviously not the same calendar date. And here they are aligned, where the count is whether they show up in the emergency department with a blood clot. And we ask the question, is pregnancy associated with thromboembolic events? So that if a woman has a clot 1 year before delivery, she shows up as a count right there. And if a woman has a clot 1 year after delivery, she shows up right there. And if she's got a clot at both times, she shows up in both places. And what we do is we group the number of accounts into bin sizes of 28 days duration. Hereafter, I will refer to that as 1 month. Notice the findings here that the rates of clots are low but non-zero at baseline, and that there is a substantial increase when the woman is pregnant, and then it returns to the baseline thereafter. And we come to the stunning conclusion that pregnancy can cause blood clots. All right? Now, this is hardly news, but at least it can be visualized and quantified in a scientific manner, and I doubt that many women would agree to be randomized to become pregnant. Okay. It's amazing. Okay, so on the next slide, we use another example of the same patients in order to get a better feel of this design. And this time of the y-axis is much more stretched because we're looking at a much more infrequent outcome. Specifically, we ask whether pregnancy can prevent bicycle crashes. And in this case, we count up again the number of emergencies that send a woman to the emergency department after falling off a bicycle. And the main finding here is a baseline rate of about 25 events per month in the years prior to getting pregnant. It then drops substantially during the second and third trimester. It recovers to about 50% the original baseline rate by the child's first birthday. And the policy implication here is that road safety advice does not need to target bicycling in pregnant women. And again, this is evidence that is drawn by linking exposure to outcome. And one of the slide advancers still is not working, so we have to use the other one. Okay, now, here I give a third example so you can rehearse your understandings and begin to start your criticisms. Now, we're going to stick with the same patients and next ask whether pregnancy can change a woman's mood. And now this is a subtle question because postpartum depression gets a lot of attention, and because some spectacular cases lead to lethal outcomes. And so in this case, the counts are emergency department visits anywhere in Ontario for an acute episode of depression. We observe a fairly stable baseline at about 150 events per month prior to pregnancy, a temporary reduction but not total elimination during pregnancy, and then a bounce back, although not quite all the way to the baseline, but this amounts to about a 1/3 reduction if you compare the subsequent interval to the baseline interval. Now, of course, there's a lot more to life than staying out of the emergency department, and these analyses don't tell us anything about the intensity of each case of depression or other nuances. Instead, the point is to illustrate how this non-randomized self-matching design is feasible, interesting, ethical, informative, and relevant. Okay, now on this slide, I move to a much more biological question and a different patient setting. All right, focusing this time on kidney transplant recipients anywhere in the major hospitals of Ontario, and the outcome is a diagnosis of a herpes simplex or herpes zoster viral infection. And the sample size is about 5,000, and we formally introduced the term baseline interval, induction interval, and subsequent interval because nobody's going to receive an acute kidney transplant immediately while they've got a rip-roaring viremia, so that we want to exclude a little bit of the interval that immediately preceded implantation so as to avoid regression to the mean, protopathic bias, reverse causality, and some confounding by indication. The main results are that there is a baseline rate of about 5 events per month in the baseline interval and a subsequent rate of around 20 events per month in the interval following a transplantation. On a denominator of about 5,000, you can then calculate a relative risk increase of about 300%, a absolute risk increase of about 15 people per month, or a number needed to treat of about 25, which then perhaps has a policy suggestion on the role of preemptive antivirals such as valcyclovir. Okay, on my 5th and final graph, I show a more behavioral intervention, and this one with results that were not intuitively obvious, at least not to me. All right, here we test whether physician warnings for medically unfit motorists can prevent serious road crashes. We use all of Ontario to avoid referral bias and selective sampling, and the accrual interval is about 4 years. That is, these 100,000 individuals are all patients who received a formal warning from their physician about being potentially unfit to drive. That's a comprehensive sample representing about 0.5% of all motorists in Ontario. And the graph shows the results as the count of life-threatening road crashes that send the patient to the emergency department, although not necessarily to the grave. Overall, there are about 40 crashes per month in the baseline interval prior to receiving the warning, and about 20 crashes per month in the subsequent year after the warning. And there's as well this clear spike during the few months immediately preceding the warning that is evidence of reverse causality. That is, some combination of prevention in the aftermath of a crash, some opportunity for a subgroup analysis, of course, for those who received it as a preemptive or as a secondary maneuver. But the big point here is that these subsequent rate is lower than the baseline rate. We can then move and collapse all of these, boy, this is really trickier than I thought. I mean, all of these graphs, these two-dimensional structures, into a few simple numbers, all right? Namely, a baseline rate expressed as the number of crashes per 1,000 patients annually. The subsequent rate, again, per 1,000 patients annually. That's an absolute risk reduction of about 2 per 1,000 per year, a relative reduction of 50%, and a number needed to treat that you can do. Once you've got these sort of overall summary statistics, there is no stopping you from doing as many subgroup analyses as your heart desires, either by age, gender, home location, or other attributes. Here's some of my favorite subgroup analyses according to the patient's a diagnosis that was underlying the warning. This time accompanied by a 95% confidence intervals, and the main finding is a check of robustness on this particular intervention, making it seem somewhat less effective for patients diagnosed with alcoholism and somewhat more effective for patients diagnosed with depression. And incidentally as well, but take a look there at that relative risk, i.e. patients with strokes really seem to take their physician's warnings seriously. The main point here is basically to reinforce some standard intuitions. It doesn't have to stop there. Here are splits not according to the patient's attributes, but the physician's attributes. And this time it's a shorter table since there are fewer physician characteristics available. But regardless of the age, gender, specialization, or experience of the physician, we find that the relative risk reduction associated with medical warnings is awfully similar. So that the powers of persuasion for different physicians are not all of that different. And of course, even more nuances could be explored, unlike almost every randomized trial I read. So here's the summary slide that leads into general interpretations and underscores my three only points. First is that the exposure crossover design allows self-matching to control unmeasured and measured individual factors. It requires a durable intervention with a clear starting date, and it focuses on outcomes that are recurrent, relapsing, or otherwise repeated. This design has, of course, lots of limitations. Here are my favorite 8. If you've got an unstable baseline interval, you're going to have to use much more complicated statistics in order to account for time trends and serial correlations. There are still lots of subtle forms of confounding that are possible around the timing of the intervention when a patient actually shows up. Conglomerate interventions are, of course, going to be vexatious in the same way that, of course, it's not the new kidney that causes the herpes virus infections. It's instead all of the immunosuppressants that are packaged with it. Inadequate sample size is a hassle in all research, but this design has a gargantuan appetite for sample size, and the limitations of sample size are probably the only reason that this design was never discovered earlier. Insufficient time durations are problematic, and every analysis I've shown you today required a 5-year x-axis. The potential for survivor bias, I think, is a very nifty nuance that is built into the baseline and induction interval that doesn't show up in the subsequent interval. And selection bias is always a problem. The design, of course, has strengths. Here are my favorite 8. The top 4 are the strengths that it shares with every randomized controlled trial, whereas the bottom 4 are the strengths it has above and beyond a randomized controlled trial. I won't belabor that further. And my last technical slide, I won't belabor either. Specifically, of course, there are lots of other self-matching designs out there as well. Here is a list of 4 of them. The exposure crossover design is different, though, because it does not involve just relative risks, brief effects, single outcomes, and an aggregated perspective. On my penultimate slide, though, I want to make one last point, specifically that I've shown you a lot of these green graphs all during my talk, and I'm still searching for a good name for them, all right? Obviously, I can't use a Kaplan-Meier graph because that's already used for a line graph, and I've considered and rejected grass field plot, Manhattan plot, and hairbrush plot. So I am open to suggestions. The best I've been able to come up with so far is bamboo plot. On my final slide, I give you my take-home message. Specifically, if people ask you what Redelmeier spoke about today, he said that the exposure crossover design is a new self-matching approach for testing clinical questions when a randomized trial is not possible. I am so in love with this, I have now forged the data pyramid with this red star here to put it on the same level as randomized trials. Many thanks.